and welcome to the program Healthy Living on Trust Television. I am Aisha Salihu. Now today on the program, we're looking at a serious maternal health issue which is prevalent globally, and that is understanding postpartum hemorrhage. I have joining me virtually Dr. Ahmad Ibrahim Mayhel, consultant obstetrician and gynecologist, to help us understand what postpartum hemorrhage is. Welcome to the program, doctor.
Good afternoon and welcome.
I know for a fact that for people who have just put to birth, I'm talking about mothers who have just been delivered of their babies, there is always some sort of bleeding that comes afterwards. But then we're talking about postpartum hemorrhage from an expert point of view. Let us start with the definition and its significance.
Thank you once again. My name, as you mentioned, is Dr. Ahmad Ibrahim Mayhel. I'm an obstetrician and a gynecologist. It's a very good question that you ask about postpartum hemorrhage, because it's a problem that affects our locality. Our women die because of bleeding. We see women die following delivery. Sometimes because of reasons we could avert, sometimes because of ignorance. By definition, postpartum hemorrhage, to a layman, one can describe it as excessive bleeding after delivery, which follows delivery, either normal delivery or following cesarean section. That's when a woman has undergone operation. But to us, obstetrician, when we describe postpartum hemorrhage, we actually quantify it to make it more objective. And with that, we can be able to institute management or even prevent the occurrence of that problem. Therefore, we define that as a bleeding in excess of 500 mils following normal vaginal delivery, or more than 1,000 mils, that's 1 liter, following cesarean section. Or we can define it as any bleeding in excess of normal low care. When I mean low care, means the usual bleeding that spots after delivery. This bleeding can either be based on the timing. It's either that occurs within the first 24 hours, that's within the first day after delivery, which is very, very important, because that's the time that the woman's general condition can change immediately after delivery, and that usually succumbs, or the woman usually dies because of inappropriate interventions. Therefore, all efforts should be put to avert this menace. Every minute a woman dies from either pregnancy or its complication. And many a times we can actually interfere or intervene to prevent this.
Okay. Now, let us look at the prevalence of this postpartum hemorrhage. The prevalence of this postpartum hemorrhage, and also what would you say are maybe perhaps the risk factors that lead to this kind of condition?
Exactly, thank you. You see, this postpartum hemorrhage, it's something that is better prevented than managed because of its previous complications. Thank God, luckily enough, there are signs or features that we look and say yes, a woman is at high risk of developing this postpartum hemorrhage, and those are called risk factors. And those risk factors could either because of the pregnancy itself, or from the mother, or from the baby. There are factors that we should look at for every woman. Every woman is a potential victim of this postpartum hemorrhage. However, there are those who are at high risk of developing this, and this includes women who have multiple pregnancy, because when a woman has multiple pregnancy, meaning that she carries twins, triplets, and so on, the uterus gets bigger. And when that gets bigger, usually after delivery, the uterus is supposed to contract so that the blood vessels within the substance of the uterus contract and stops the bleeding. However, in such excessively enlarged uterus, the woman will continue to bleed after delivery uncontrollably if interventions are not instituted. Another risk factor is for those women who have excessive water, what we call the liquor, in their uterus during the pregnancy. So after delivery, those women are also at risk of developing this postpartum hemorrhage. Those patients who have had similar occurrence of postpartum hemorrhage in the past, for any reason that makes a woman to develop postpartum hemorrhage in her previous pregnancy, should be watched out in the current pregnancy or in this pregnancy, because that same reason could recur. Other reasons include those who have had cesarean deliveries. That is, a woman has had operation to remove her baby in the previous pregnancy or pregnancies, because there is interruption in the continuity of the uterine and other layers. So that could prevent the uterus to contract in this index pregnancy. Another reason is for a woman who has had obstructed labor, meaning that a woman who has delayed, who has taken time to deliver, who has overstayed during the hours of labor. So because of the problem of the contractions that the uterus undergo during the process of labor, the uterus usually gets exhausted. And once that happens, usually it will become quiet and weak after delivery. So it will not contract enough to stop bleeding. These are some of the reasons or risk factors to predispose a woman to developing postpartum hemorrhage.
Okay, I understand that you've talked about a woman who must have suffered from previous postpartum hemorrhage, multiple pregnancies as part of the risk factors, all the causes, and then also prolonged labor, and in some cases perhaps cesarean section, and also uterine abnormalities. Now, I'd like for you to walk us through the common causes such as uterine atony and trauma during childbirth. I'd like to know how these contribute to PPH.
Yes. Because of timing, that's why I could not exhaust all the causes. Uterine atony means uterine quiescence, meaning the uterus will become quiet after delivery. Ordinarily, after delivery, the nature makes it such that the uterine vessels that are interlaced within the myometrium, that's within the substance of the uterus, contracts. And when they do contract, the vessels inadvertently also contract and the bleeding gets secured. Some instances will make this uterus not to contract, to become quiet, and that's when we term that as atony, that is non-contracting uterus. And this usually happens, as I mentioned, in those who have suffered prolonged labor, because the uterus has been exhausted, all the energy within the myometrial cells has been exhausted, so the uterus become quiet, it will not contract, it has already done its work. Just an imagination that it has overworked itself, so it's exhausted. Similarly, for a woman who is just who is carrying her first pregnancy, because nature makes it such a way that following 2-3 deliveries, the uterus becomes sensitized, such that after delivery, there are enough cells or receptors of these natural oxytocins that will make the uterus to contract. So because these people are just starting, they are just primates, this is their first pregnancy. So the uterus doesn't have that experience to contract. On the other way, when you look at it, for a woman who has delivered several times, let's say 7, 8, 9, 10, and the rest, those ones, because the uterus is laxed, it has become a bit weak naturally. So that's also another reason that will make the uterus not to contract. So these are some of the reasons why uterine atony occur. On the other hand, you have other causes like the genital tract lacerations or injuries. And these injuries are also a very significant contributor to postpartum hemorrhage. I should have mentioned that earlier when I was describing the risk factors. And these injuries could start from outside inwards, that is from the vaginal orifice, that's outside the woman's private parts. She can have a cut, and that usually those cuts are usually ragged, they are not usually fashioned. and the bleeding can occur in any size.
Okay.
And as you go a bit deeper, it gets to the vaginal walls. They could also you can also get torn and bleeding will develop from that.
Okay.
But we'll go up again along the genital tract of the woman from the cervix, because that's the opening into the womb. That can also get lacerations. And when that happens, because the muscle layers in that particular portion of the cervix are less, so it will not contract. Usually you have to do the operation and suture it.
Yeah.
Also, the main uterus itself, it can also rupture. So when that happens, of course, the bleeding is dreaded, and the woman usually can have can die from that. Then also on the sides of the uterus, also what we call the blood ligaments. There could be rupture there also. If they usually, as this complication of this uterine rupture, the bleeding can extend to the sides of the uterus, and those sites are usually well reached in blood vessels, and those are very significant causes of maternal mortality.
Okay, so we have been talking about the risk factors and the causes. Now, it's not enough to talk about all of these without, first of all, recognizing the symptoms, because I know there are lots of women who may be undergoing this particular condition, but they're not aware that this is what they're going through. Could you briefly tell us what are the symptoms that any woman should look out for, just so they know or they identify with this particular condition in an event they have it?
Basically, postpartum hemorrhage is usually a clinical diagnosis. You don't need anything to usually say you have to use a sophisticated gadgets or diagnostic tools to diagnose it. Usually subjective and clinical. We look at the bleeding. Usually for a woman who has never had, who has never delivered, or where the attendant is not experienced, definitely it will be difficult to determine that. But where delivery occurs within the hospital, the clinicians usually estimate the blood loss. Thank God for the new innovations of quantifying the blood loss, which is a bit cumbersome, but in the hospitals, that is usually obtainable. So, as I mentioned in the definition of postpartum hemorrhage, that's any bleeding that is in excess of 500 mils. And usually, when that happens, the woman experiences some symptoms, and these include, obviously, she'll see that she's soaked in blood. All her wrappers will be soaked with blood. The bed where she delivers will be soaked with blood. Then also she begin to, depending on the degree of the blood loss, she begin to have some symptoms, and these include blurring of vision, palpitation. That means she'll be having her heart beating faster than usual. Then she'll be feeling dizzy, and she can even collapse. So these are usually the clinical symptoms that one will see, but usually this occur when complications begin to set in, and the woman cannot become incapacitated. She cannot do anything. The next thing, she gets into breathlessness, and she can die if interventions are not put in place appropriately and promptly.
Okay, thank you so much for walking us through some of the symptoms. I'd like to know, what would you say is the age group or the demography of women that are likely to come up with this issue? I know we're talking about maternal health concerns, but then what would you say is the age group or the demography for women?
Yes, these women, majorly, they are all women within the reproductive age group, from 18 years to 44 years. Usually. So these women usually are the ones affected. However, depending on the locality, when you look at in Nigeria, for instance, when you take Kebbi State, for instance, in Kebbi State, you realize that women get married early. Because of this early age of marriage, you see that a lot of complications actually occur in these women who are a bit younger. Women get married from 18 years, 17, 18, 19, usually, and the childbearing starts very early. As against those in the southern part of the country, where we are beginning to see trends in late maternal age, i.e., the women get start to have their reproductive career in the next age group. So it's cut across all age groups. There is no particular age that is peculiar for postpartum hemorrhage. Any woman who delivers is at risk of that. However, those who start their obstetric career late in their life are also more at risk. That is elderly primary gravid. And these women, because their uterus are usually not used to the process of pregnancy and delivery, the complications usually set in that age group too.
You've walked us through some of the causes, risk factors, symptoms, and also the age groups and women at risk of postpartum hemorrhage. I'd like now for us to move on to treatment and management of this particular maternal health issue.
You see, generally when we talk about the management of health conditions usually begins from making a good diagnosis. And this diagnosis is usually gotten from the clinical history, examination, and if there is specific investigations to be done, then the specific treatment to be instituted. The hallmark of this, the best form of management for postpartum hemorrhage is prevention. That's why, as a routine in general practice everywhere, either in the hospital, in the maternity homes, even the trained birth attendants that go to homes to assist women deliver, they have been taught of all this. And one of the central points of prevention of postpartum hemorrhage is what we call active management of that stage of labor. And in that, there are steps we do. First of all, immediately after delivery, one should get prepared. Immediately after delivery, once the baby is delivered, we give the woman what we call oxytocin. And these oxytocin, they help to make the uterus contract. Aside the natural substances that will make the uterus contract, we augment that. So we give that usually on the muzzle or intravenously, IV. Then the second step is we try as much as possible to deliver the placenta, because when the placenta is not delivered, the uterus will not have the capacity it's supposed to contract adequately, because something is hindering its contractility. So deliver the placenta immediately after delivery of the uterus. Then thirdly, we make sure that the woman continue to rope up contractions on the uterus. Either the birth attendants or the woman herself can do that intermittently. Every 15 minutes, she will do that. Every 15 minutes, she will do that to rub up contractions. And by the time she's putting her hand on the uterus, she's rubbing it. That will stimulate the natural processes to make the uterus contract. This is central to prevention of postpartum hemorrhage. Then, as I mentioned earlier, that you have to first of all identify those women who are at risk, so that you institute more close monitoring on them when they come in labor. So that is started earlier in their pregnancy. You identify those women that this woman is at risk. For instance, if a woman has multiple pregnancy, it's not the type of woman that you allow to have a home delivery, and it's a woman that should have a hospital delivery in the presence of an obstetrician, where should be the postpartum hemorrhage will be prevented in her. Then other parts of the management include blood transfusion and any other IV fluid administration, just to boost her circulation so as to prevent asphyxia or hypoxia rather, and then prevent the sequelae of maternal morbidity and mortality in her. So these are the stages you follow when you want to prevent mortality from postpartum hemorrhage. Then overall health education, you educate the woman on how to look for those signs and how to look for seek for medical attention once they are pregnant.
Okay, you have stated a number of management techniques. I understand that apart from where we have to use medication to contract the uterus in the case of postpartum hemorrhage, I also know that in severe cases there is surgical procedures. I'd like for you to, simplify it for us, because there are some women who may be scared, because especially if you've gone through a surgical procedure before now to conceive a child, to to give birth. You've already gone through that, and then you have to deal with postpartum hemorrhage, and in severe cases now there is a need for another surgical procedure. I'd like for you to simplify it for people, so just so the fear does not overshadow or overtake them.
There are women who there are surgical procedures in the management of postpartum hemorrhage, and these surgical procedures I could classify them as either less invasive and those that are invasive. When I talk about less invasive, and these include like suturing of the bruises and lacerations around the perineal area, that's around the vaginal area where the cuts occur. One, or suturing of the lacerations around the cervix, as I mentioned earlier, or repair of the uterus in the womb of the woman. And usually you see this is a bit more invasive, and this usually the woman has to undergo the frank surgical procedure by opening her abdomen, going to get the uterus and look at it. Usually when we see the rupture, usually we look at how feasible it is to operate on her to save her life. The principle is we do the fastest and safest surgery in her. Most of the times when we see uterine rupture, depending on how early the woman presents, if it's very early and the wound edges are fresh, and maybe we look at the fertility of the woman if she's desirous of pregnancy, occasionally the obstetrician may decide to conserve the uterus by repairing it, and perhaps maybe she may take the pregnancy later, but that's very rare. Then the other part is when you repair the uterus, you now tie the tubes, because any uterus that could rupture during the normal process of labor is not the uterus that should be allowed to carry any pregnancy. So that first decision I mentioned, the woman has to be informed that if she chooses that option, that she should know that that's a very risky decision she takes. But you cannot impose on a woman that she must take this particular option. You only counsel. But advisably, you repair the uterus and tie the tubes. There are instances where you open the woman and you now see that you cannot even repair the uterus. So you have to remove the uterus, because that's the only way the woman can survive. And that may be the fastest and safest surgery for her. Then in that case, you remove the uterus. Of course, definitely you counsel the woman and telling her of her future fertility prognosis, that she will not be able to bear her own child biologically. But she has other options of adoption and fostering and likes of it. And other less invasive surgical procedures that I should have mentioned, when the woman develops postpartum hemorrhage, there's what we call, when you open, usually this happens either during when the process of the labor or the delivery is through cesarean section. After you deliver the baby, you deliver the placenta, usually you look at the uterus and see if it's the type that will contract. If the type that contracts should have contracted while you're still intraoperatively. Therefore, when you assess that, if it's not contracting, then you have to put other things, other measures, like you put some threads, what we call the village or the breast sutures generally. We apply sutures to act as tamponades to contract the uterus, and usually it saves a lot of women's life. Then less invasive, we can use what we call the balloon tamponade method, where we instill water into the balloon. There's a special balloon catheter that we use. If we don't have that in our local hospitals here, we improvise with the usual urethral catheter passing through a condom and then inflated with about 500 to 700 mils of normal saline. And that will help to block the blood vessels within the uterus. And when that happens, many times we've seen success with that. So these are some of the surgical procedures we employ in the management of postpartum hemorrhage.
Okay. Earlier you talked about prevention being better than management techniques. I'd like for you to touch on some of these preventive measures, just so we don't have to later manage PPH. Let's look at preventive measures.
Okay. Generally, when we talk about prevention in medical practice, it's always good to discuss that in this lane. You talk about the primary prevention, secondary prevention, tertiary prevention, generally. Yes, when you talk about primary prevention, meaning you identify the risk factors to that and prevent them. By secondary prevention, you mean you diagnose that if it has already occurred, you should be able to diagnose it as early as possible and treat it to prevent the development of complications. Then by tertiary prevention, we mean that you manage the complications that ensue as a result of that. So we'll go back to the primary prevention. See, in primary prevention, this has a lot of work to be done in this aspect, i.e., beginning from health education, educating the women on what postpartum hemorrhage is, how it looks, how the complications develop, and identifying those women who are at risk, and then following them up when they are pregnant and prevent this. Other things include women empowerment. All these are part of primary prevention. When you empower a woman, she will take decisions on her life, and she can take care of her health better. So you see, this is another part of primary prevention. Then young child education, very, very important. When you give education to children, they will get to know about the condition. And once they have the knowledge, it's better when you want to counsel them, and it's better when you want to manage them. It's better for them to that's when you have the right to seek for medical attention. That's the aspect of the primary prevention. So for postpartum hemorrhage, we usually identify those women who are at risk. We institute all this management. And then also, as I mentioned, primarily we follow this active stage, management of that stage of labor. It's all part of it. Then the secondary prevention is we identify postpartum hemorrhage as early as possible, not until complications set in, where she becomes decompensated and she has developed complications of either heart failure or hypoxia. So we get that as early as possible. Once the woman delivers, we've instituted all this management and we see that they are not working. We should be able to recognize that as early as possible, get blood, get IV fluid, get more obstetrics, which are uterine tonics that will help to control the uterus, then institute that appropriately. Then I mentioned the third level of prevention, that is tertiary prevention, that is you now battle with the complication that have ensued as a result of postpartum hemorrhage. So you follow these steps, these 3 steps, you'll be able to prevent postpartum hemorrhage.
Thank you so much, Doctor. I'm afraid that's the much we can take. We have been speaking with Dr. Ahmad Ibrahim May Ahu, consultant obstetrician and gynecologist. Thank you for your time.
Thank you so much.
All right.
So grateful.
With that, we've come to the end of the program, but do remember that in case of any health concerns, when there is an occurrence of postpartum hemorrhage, you need to seek medical help as soon as possible. These are part of the maternal health issues, and we need to start talking about them and addressing them accordingly as we also move further to seek medical help promptly. With that, we've come to the end of the program. For comments, contributions, suggestions on this episode, do well to comment, follow, like all of our social media platforms. Join us again on another episode of the program, Healthy Living on Trust Television. I'm Aisha Salihu. Thanks for your time.